Points of discussion originally were pyloric stenosis, but we'll discuss that at a later stage. Duodenal atresia, jejunoileal atresia, and stenosis will be discussed for today, and colonic atresia we'll also discuss at a later stage. Okay, so with regards to duodenal atresia, it's a congenital absence or complete closure of a portion of the lumen of the duodenum due to defective fusion of the foregut and the midgut with failure of recanalization. It occurs in 1 in 5,000 to 10,000 live births, and males seem to be more affected than females. With regards to how it occurs, as I've said, there's failure of recanalization, which is an intrinsic cause of this problem. There are also extrinsic causes associated with this defective development of the adjacent structures, and other teratogens have also been implicated in this. With regards to intrinsic lesions, the failure of recanalization, which occurs obviously in the embryological stage, the 4th week of gestation, if we just focus on the picture on the left, we can see that the duodenum begins to develop around the 4th week of gestation, and that is from the distal foregut and the proximal midgut. During the 5th and 6th weeks of gestation, the duodenal lumen then temporarily obliterates completely because of the proliferation of epithelial cells. There's vacuolation, which occurs, and degeneration of these cells happens around the 11th week, which then results in a recanalized duodenum. The embryological insult in this period is thought to what leads to their intrinsic webs, atresias, or stenoses. With regards to the extrinsic form, or the picture on the left is just one example of it, and that would be your annular pancreas. You could also get a preduodenal portal vein or a secondary to malrotation, which leads to your Ladd's bands. With the annular pancreas, this does warrant special mention because there's a form of obstruction which is likely also due to an intrinsic duodenal developmental problem, as well as the external compression. So the annular pancreas is a visible indicator that there is an underlying stenosis or atresia present. Again, between the 4th to the 8th week of gestation is when your pancreatic buds merge, and the tip of the ventral pancreas seems to become fixed to the duodenal wall, which forms a non-distendable ring around that portion of the duodenum and the descending part of the duodenum. And then the annular pancreas is also associated with duodenal obstruction. As I've said, the biliary tree can also be affected, and that can be to the proximal or distal part of that as well. There's several varieties of intrinsic and extrinsic lesions, as we discussed, and 81% of those will cause complete obstruction, while about 20% of that causes partial obstruction to the duodenum. Then more than 50% of the patients affected by duodenal atresia also have other associated congenital abnormalities. Up to a third have trisomy 21, a third will have isolated cardiac defects, and a quarter will have other gastrointestinal issues as well. 45% of the patient population will be premature, with a third of them exhibiting intrauterine growth restriction as well. Okay. Then, as I've mentioned, the associations, they can be associated with Down syndrome, annular pancreas, in the third with congenital. Also, malrotation is something to think about. And then we've mentioned the multiple other atresias. Then with regards to the classification, we'll follow the Gray and Scandalarcus classification, which divides it into 3 types. Type 1, which is the majority of the cases, more than 90% of cases present with this, and there's an obstructing septum or web formed from the mucosal and submucosal, but with no obvious muscularis defect noted. The mesentery is also intact with this. The one thing with this that we need to be aware of is what's called the windsock deformity, and that is when the membrane is quite thin and elongated and seems to bellow from the second portion of the duodenum right into the third and fourth portions of the duodenum. The septum itself that forms in the second part can be of varying thickness from a couple of millimeters to several millimeters. It can be an imperforate septum, which will then cause a complete obstruction, or have a central perforation, which will cause an incomplete obstruction. And then the diameter of this opening will then obviously inversely be the degree of your obstruction. And then with regards to the intrinsic blockage, this can happen in almost any part of the duodenum, but like I said, more commonly in 85% of cases happening in the first and second part of the duodenum. With regards to the intrinsic obstruction, particularly with angular pancreas, there is this ring of pancreatic tissue which is encircling itself around the duodenum and causes partial obstruction. But like we said, with that, there's often associated underlying duodenal atresia and developmental problems with the recanalization. A preduodenal portal vein, my apologies, can also then cross the anterior surface of the duodenum rather than posterior in its normal anatomical association, and may cause incomplete obstruction or compression of this as well. It can also be intestinal malrotation, and which results in Ladd's bands, also again causing obstruction more in the second and third portion of your duodenum. And many of these patients with extrinsic causes are the patients with the cardiac lesions, as mentioned. Then moving on to presentation and diagnosis. The benefit to antenatal diagnosis is that you can have parent counseling, and that also further investigations can be done for associated anomalies. And some of the antenatal features that can be found is polyhydramnios seen, and if fetal ultrasounds are done, a double bubble will be noted, and that's often in late gestation. Only in the 7th or 8th month of gestation is that seen. At that point, one can also recognize an annular pancreas. I must say, in South Africa, I think our antenatal care is not on par, and we often don't have them diagnosed antenatally in our settings, unfortunately. Then with regards to the neonatal period and actual clinical presentation, repeated bilious emesis or vomiting is what can be noted. There's also minimal distension because the obstruction is so proximal. It's often just a very subtle upper abdominal fullness that is noted. There may be a report of poor passing of stool or flatus. Also, feeding intolerance is another one in the baby, because of this ongoing vomiting may present with dehydration and electrolyte abnormalities. Then moving on to further investigation, if we look at the plain film, I know I mentioned the double bubble with regards to an ultrasound done antenatally, but postnatally, this is what the classical sign is referred to as, where you can see a distinct stomach bubble and a distinct bubble of the duodenum, and a pretty much gasless abdomen in the rest of the distal bowel. With regards to further investigation, if you're still unsure if the signs are quite subtle, especially if the ampulla of Vater is distal to where your obstruction is, that you may not get the bilious emesis, and that's in 10% of cases. One can then do an upper GI contrast study as seen there, which will also then nicely outline where the problem may lie. With regards to the management, placement of an oro or nasogastric tube to aid decompression. Fluid resuscitation is important, and to correct those electrolyte abnormalities. With regards to the blood work, that's important. A full blood count, or CBC, is important. Urea and electrolyte panel, as well as a calcium, magnesium, and phosphate profile, and a coagulation studies are important as your preoperative workup. Also, an electrocardiograph. is important because of those associated cardiac abnormalities, and we look for other structural abnormalities and intra-abdominal issues with an abdominal and spinal ultrasound. If there's any concern that this is a foregut volvulus, surgery at that point is quite emergent. When looking at the operative management options, we can either do it via open procedure and do a laparotomy by utilizing supraumbilical incision, transverse incision at least, or it can be done laparoscopically, and it's the following methods are amenable by both approaches. Okay. One needs to adequately mobilize and expose the duodenum so that you can see the extent of the problem. So you need to mobilize your colon inferiorly. You also need to then cockerize your duodenum adequately so that you can see the full extent of the problem, in which case it may be necessary to taper it to decrease the dilatation. The other option, if you're going to excise a web, in the case of a type 1, we can do a Heineken-Michelitz duodenostomy. And then our other options in terms of bypassing that and a duodenostomy using a diamond-shaped configuration is another approach that one could use. The jejunostomy is also another way to overcome very tricky space to work in, and you can sometimes aid yourself by doing that approach, although it runs the risk of a blind loop syndrome. And then the less favorable and often not used now is the gastrojejunostomy, and that's because of marginal bleeding and the risk of ulceration from that particular procedure. With regards to the complications, intraoperatively, you may not correctly identify the area of obstruction. As I said, that windsock deformity can be quite tricky as the thin membrane bellows quite far distally, and you may not actually notice that. The one way to overcome this is to pass a catheter both distally to ensure that there are no additional webs or areas of stenosis or atresia, and then also to pass a catheter superiorly even into the stomach to make sure that there's adequate drainage from the stomach and there's no obstructing web more proximal than you thought to put your anastomosis, and thereby mitigating the missed distal web as well by doing that. Post-operatively, if the infant is then taking a very long time to feed, more than 3 weeks, one can consider an upper GI series, and also to delineate any residual anatomic obstruction to see if there's any anastomotic stenosis, also any previously unrecognized obstruction, or just to see what the peristalsis activity of that particular section of bowel is as well. Some late onset complications is a partial web, narrowing of your anastomosis and stricturing over time, poor peristalsis and further dilatation because of obstruction. And that can also be dealt with any of the surgical procedures described previously, as well as prescribed previously, with outcomes of any of the procedures described and operating on these babies of up to 95% survival. Okay. In the JEJUNOILEAL atresias, they occur in up to 5,000 births, and therefore are more common. About a third of them are associated with prematurity and being small for gestational age. Males are as affected as females. With regards to how this occurs, the vascular disruption in fetal life has been the proposed and accepted theory based on studies done previously, and it's localized intrauterine vascular insult, which will to the developing bowel, which causes ischemic necrosis and subsequent resorption of the affected segment of bowel. Sometimes the additional pathology that actually supports this is because there can be intrauterine fetal intussusception, malrotation with a midgut volvulus. There can be thromboembolic occlusions, transmesenteric internal herniation and incarceration, or a snaring of the fetal bowel in a gastroschisis or amphalocele, which supports this hypothesis of ischemia. Then the ischemia adversely influences the structure and the subsequently forming of the remaining bowel. Histologically and histochemically, there are abnormalities, and that can even extend as high up as 20 centimeters from your point of atresia, your proximal segment of your atresia. And then the distal bowel is potentially normal functioning bowel. There has been a proposed genetic or familial, although the genetic contribution of jejunoileal atresia is unclear. Shorter and his colleagues came up with a novel system whereby they looked at the patterns of inheritance with regards to the different types of atresias, and they've come up with their own classification, although it's not in much use of much clinical significance. It is interesting to note. Then the classification that we are going to chat about would be your Grossfeld classification, which looks at stenosis as well as other pure types of atresias. The stenosis is defined as just a local narrowing in the intestinal lumen without any disruption of your intestinal wall or your mesentery itself. And when we look at type 1, it may sound that type 1 can also take the form of type 1 by just having a fenestrated membrane as well. And patients with jejunoileal stenosis usually have normal length of bowel. When looking at type 1, we can see there that it occurs secondary to, again, a membrane or a web forming within it, encompassing the submucosa and the mucosal layer with an intact muscularis layer. And on gross inspection, it may look as though there is bowel continuity. Definitely, it looks like that with mesenteric continuity as well. But the proximal bowel is often dilated, while the distal bowel, as you can see in the picture, looks quite collapsed and a lot more attenuated. With increased luminal pressure, that proximal portion starts to dilate a little bit, and a bulging web may also cause that windsock effect like we discussed in the duodenal atresia, and we just need to be aware of that as well. With this, there's also no significant shortening of the bowel itself. With regards to the type 2 atresia, it's a largely dilated, blind-ending proximal segment with a thin, usually thin fibrous cord, which is then attached to the more distal and collapsed section, more distally, with an intact mesentery. Also, total bowel length with type 2 is usually preserved. Then to the more serious types, type 3A, we can see that the atresia ends blindly with no fibrous cord connection between the proximal and distal portion. Again, the proximal portion seems quite dilated, while the distal portion is a lot smaller caliber and looks more collapsed. There's also, as we can see, a mesenteric defect in this. Usually the total length is slightly less than normal, and that's owing to those vascular accidents where there's been uterine resorption of the bowel in between those sections. Then the type 3B atresia, known as your apple peel or Christmas tree type configuration, and it's a very proximal jejunal atresia with the absence of the superior mesenteric artery beyond its origin of the middle colic branch. Also, agenesis of the dorsal mesentery is present with significant loss of intestinal length and a large mesenteric defect, as can be seen in the picture. The distal bowel is quite decompressed and lies free in the abdomen, and also takes on this helical configuration, which is where it gets the name characteristic of an apple once it's peeled. With regards to this, again, it has been found in families, and like I said, the genetic pattern for type 3B has been attributed to an autosomal recessive mode of transmission, seen quite significantly between siblings where they have identical lesions and in twins as well. There can be associations with other abnormalities with type 3B. Significantly more, about half of the presentations are accompanied by a malrotation. There can also be short bowel syndrome in up to 75% of the cases purely on the native bowel without resection even, and then carries with it a high morbidity rate of 63% and a mortality rate of just over 50% of the affected population. Then with regards to type 4 atresia, this is multiple segmental atresias or a combination of 1 through 3, and that has been grouped together as a type 4. And to date, a type 4 has been almost uniformly fatal and doesn't have a good prognosis at all. The majority of cases with multiple segmental atresias are sporadic, and there's no family history of gastrointestinal defects often with this. And then a differential diagnosis for what we're seeing can be a malrotation with or without a volvulus. If there's a meconium ileus, if there's intestinal duplication, any internal herniation, if there's colonic atresia, a paralytic ileus, or total colonic aganglionosis can also present the same way, as well as an infant with hypothyroidism or a mother on medication that causes a similar problem. Then the clinical presentation, again, antenatal diagnosis or clues are there, such as polyhydramnios, and then if you can get a fetal ultrasound later on, you'll note dilated loops of bowel. The presentation within the neonatal period can happen anywhere between 1 to 3 days, depending on the level of obstruction. And then the baby will present with obstructive symptoms, being the bilious emesis. The distension on this baby is more significant of something very distal rather than just a jejunal ileal. So maybe misrepresenting the abdominal distension a little bit on that, but that is another finding. And yes, so then with regards to the bowel obstruction noted by the bilious emesis and the distension, there may be meconium, and that may actually appear normal or can look like little gray plugs that are past per rectum, and often that can be a little bit disconcerting as to why is the baby passing meconium, but there's such gross features of obstruction. With regards to the management, again, these are neonates, so we want to look after them as best as we can, maintaining their heat. Always put in an oral or nasogastric tube, preferably size French, but if you have a tiny neonate, then obviously a more appropriate size to them. And also to aspirate whatever comes back, just to see the color and the volume of aspiration. And intravenous access is important, whether it be via central line or peripheral line initially for fluid resuscitation, and maybe later on for parenteral nutrition to consider something more long-term. And central access, blood workup as for duodenal atresia, again to do a full blood count, a UNE, CMP, coagulation profile is also important. Monitoring the inputs and outputs because they are prone to dehydration and third space losses. And then also antibiotics, especially when you have an impression of perforation or there's other concomitant infection. That's important. In operative management, if we're going to go surgical, if there's any indication of perforation, then one would advance to surgical management quite quickly, even if the diagnosis is not completely confirmed, but that would then trump your need to operate. If you're going to do a traditional transverse incision, it can be supra or infra-umbilical. the step towards doing an umbilical incision, where you just vertically then incise the sheath to create some adequate exposure for yourself, or a laparoscopic approach where you start laparoscopically and identify the atretic portions and then extracorporally fix those segments is also being done, and often easier to do it extracorporally because if it is a tiny neonate, there's very little space in which to work. Some of the surgical considerations is finding the location of the lesions and any associated conditions, as I've explained earlier, also the anatomical findings, and then determining patency distally, which one can do intraoperatively, again, by passing a small feeding tube and with instilling saline into the bowel, noting where it dilates and also whether it passes rectally. Then also the length of remaining bowel is important to measure, especially when tapering, and also trying to limit your resection so that you maintain that as best as you can. So then your location of your lesion, this particularly depicts type 3, but a 3A at least, but and when you do your resection, to resect a little bit more proximally on the proximal end and a little bit more distally, because as we said, those functional portions can extend quite far back. Then one can do end to oblique anastomosis of those in order to gain diameter on your distal portion. You can also taper those portions so that your calibration between the proximal and distal portions are more or less even. When looking at the length, this is measured on the antemesenteric border, and a length of more than 80 centimeters with a competent and intact ileocecal valve is an ideal scenario, but it's not always possible. There are length gaining procedures, but they're often not the first choice to do when operating at the initial operation. When tapering, you can taper for up to a length of 35 centimeters, and that's being quite generous. You can either do a hand-sewn tapering method, or you can use a JEJUNOILEAL stapler as well in order to do that. You can also use a plication method where just the serosal layers are incised and then approximated, with the infolding portion can be quite long, but not more than half of the diameter. The same with the folding method. You don't want to go too deep and thereby obliterating and blocking the lumen that you have created. With regards to post-operative complications, as with the duodenal atresia as well, infection is always one of the things leaking from your anastomosis site. There's any obstruction not previously noted or stricturing down of your anastomosis if you've done more than one, and even one. And then the significant complication, which is evident later on, would be your short bowel syndrome. Immediate post-operative care is concentrated on providing parenteral nutrition by central line, maintaining the fluid and electrolyte balance and keeping a close eye on that, and then also initiating of enteral feeds once your aspirates are quite low. There's no absolute number, and this differs from institution and surgeon and medical team involved, but once aspirates are clear and minimal, then one can initiate enteral feeds also in a stepwise approach as per institution. This is more for interest's sake for bowel lengthening procedures, like I said, are not advised at your initial surgery, but there's the longitudinal intestinal lengthening and tailoring procedure, or otherwise known as the LILT, which does gain you length. I think technically quite difficult and does place a lot of pressure on the mesentery when doing it. Then you get the serial transverse enteroplasty, also thereby gaining length, but changing the configuration of the muscle fiber orientation, and a slit procedure. The colonic Atresias we won't go through at this point, and that concludes the talk. Thank you.
Okay, Crystal, thank you very much for keeping to time. And just for time constraint, we decided not to include pyloric atresia and colonic atresia. Crystal, there will be lots of advice by the seniors. I just wanted to mention that we have not done Heinicke Mikulic's duodenoplasty or jejunostomy for a duodenal atresia. I can't remember. So I would like to know from Dr. Emil and Prof. Hadley if they have ever done it. That's number one. And about small bowel atresia, I'm sure you know, and we all South Africans are very proud that the etiology was discussed or described by Professor Lowe and Dr. Christian Bernard when they did those experiments in the puppies. And just type 4 atresia, I I heard you saying that they are uniformly fatal. I think that's not the case. Depends on the length of bowel. So that's not the case. And use of transanastomotic tubes for feeding, we will leave it for the later discussion. So I will now request Dr. Emil to give his opinion, present his views on this topic. Sharif, my apologies if I did not clarify. That was, I think I caused a little confusion. I thought it was only small bowel atresia, but Crystal has also spoken about duodenal atresia, but you can
Well, yeah, I
give
mean,
your
the
thought.
duodenum is small bowel, so I can't
That's
fault
correct.
her.
Yes. Sorry. Okay, you can go ahead. Thank you.
No, I just want to thank you again. I want to thank Professor Chitins again for the invitation. And I see Professor Hadley there also on the call.
Yes.
And Larry was the first South African pediatric surgeon I met. We met on a flight on the way to a PAPSA meeting. And I have to say, I've maybe never thanked you, Larry. I'm sorry, but I owe part of my position here at McGill to him because he was one of the external reviewers for my promotion. So I think he gave a good review. Otherwise, I wouldn't have been in this position. So thank you, Larry, many years later. And Crystal, that was a very excellent review. I just have to share something with you. I was laughing as I saw your background because I was in Africa when COVID struck last March and I had to come back in a hurry from Senegal. And I was in quarantine and our hospital had just bought Zoom. And so they were teaching us how to use Zoom. And the instructor had this background and it was mid-March. It was very cold. We had a lot of snow. And I kept asking him, where are you doing this from? Where are you doing this from? And he never answered. And I thought, gosh, that's really rude. Why can't he tell me where he is? So I learned a lot about Zoom since.
Sorry, I
Um,
also haven't played around much with the background to change it, so I apologize if it was distracting.
yeah, beautiful, beautiful background. I did focus my comments on small bowel and colon, but I do want to just make a few points about the duodenum. So annular pancreas, first of all, that was actually very fascinating because if you look at the history, and I'm also a bit of a history buff, I like to look at the old papers. Um, Surgeons for decades in the early part of the 20th century up to the 50s were removing the annulus. And of course, many of these patients would die from pancreatic leaks, but they were also wondering why is not their obstruction resolving? And we've really learned that there's probably not an extrinsic compression issue at all. It is really the internal atresia or stenosis that accounts for it. So it's really a marker for a duodenal intrinsic problem. The other thing you mentioned is when to do a contrast study when you have a double bubble. And that's a very important point because, as surgeons, we do not like complete obstructions, right? We like partial obstructions more than complete, but the only exception is a duodenal obstruction. When you have a partial duodenal obstruction, i.e. a double bubble with some distal air, you have to entertain the possibility of a midgut volvulus. And that's the patient who should get either immediate exploration or an immediate contrast study. If you have a simple double bubble, especially if it was diagnosed prenatally, but even not, but if you have a double bubble in a stable patient, no distal air, that's either going to be annular pancreas or duodenal atresia. There's really no indication for doing, in my mind, a contrast study on those patients. Um, the other thing that I did want to mention also is the issue of TPN. I think, Milan, you mentioned it earlier. So for duodenal atresias, we typically put transanastomotic tubes. And in fact, most of these patients do not get a PIC or TPN at all because they usually use a transanastomotic feeding until we're ready to feed them by mouth. For duodenal stenosis, where there's a diaphragm, windsock, web, whatever you want to call it, I do not do an anastomosis. I do not do a bypass. I always do a duodenoplasty. And it's really not so much about excising the web. When you open the duodenum laterally, you already disrupt the web enough. And in fact, I don't try to do much to the web because often the ampulla is coming right at the same point. So I might excise, if there's really a true windsock, I might excise part of it distally. And there's a beautiful, some beautiful pictures of windsock in my book, but I really just do a duodenoplasty. And I have to say, maybe this is my bias, but I don't find a huge need for laparoscopy in most of these patients. I mean, they can be done through a very small cosmetic, it is minimally invasive surgery still, but it's not laparoscopic. So you know, with all due respect to the people who use laparoscopy for many of these, I don't find really much use. So I'm just gonna go through, I think you all know this, it does help very much to speak about where the obstruction is when we're talking about neonatal intestinal obstruction. This is a paper I'm going to share with you after the talk. I'll send Milan some papers to share with the group. But this is a paper from Dr. Ricketts almost maybe a quarter century ago or more. And even though the timing of intervention has changed for some of these, the workup is really pretty much the same. And it's just a great synopsis on the workup of a neonatal intestinal obstruction. I always share this very early with our fellows when they come and start pediatric surgery. So here you have two babies, and they're both transferred in maybe on the first day of life with bilious emesis. And you see one on the left that's quite distended and has these corresponding films. And you see one on the right that is really scaphoid and has these films. And of course, the next point is, what do you do with these? And because of the time, I'm not going to pause too much, but really the differential diagnosis before you even decide, okay, what I'm going to do is, you know, in surgery, we think backwards. You know, I mean, the SOAP mnemonic of doing subjective and then objective and assessment and plan is a great way to learn medicine. But really, if you think about how we practice, within a minute or two of seeing a patient, we're already thinking what the diagnosis might be. And then we think backwards to confirm or not confirm that diagnosis. So when you see a patient like that, and you know that you have obstruction distal to ligament atretes, what is the differential diagnosis? Well, there's not a whole lot. It's intestinal atresia, meconium ileus, meconium plug or small left colon syndrome, and Hirschsprung's disease. That's pretty much it. So then what is your next step? The next step is to do your contrast enema. And that's not always intuitive. In fact, until now, we often talk with a radiologist because if they see a proximal obstruction, they want to do an upper GI first, and that does not help. The only time, again, that an upper GI helps is if you're suspicious of a midgut volvulus because of a partial duodenal obstruction. So in the contrast enema, you go in and you really want to ask three questions. Is there a microcolon? Can you reflux back into the distended bowel? In other words, there's no true mechanical obstruction. There's continuity of bowel. So something like a meconium ileus, which you probably don't see in Africa very much, but here in Quebec, we see it very commonly. And is the colon patent? Because as you mentioned, you can make a small incision, eviscerate the entire small bowel, but it's not always so easy to explore the colon and confirm patency. And we know that multiple atresias can exist. So if you haven't done that, I like to leave a Foley in the rectum and then have the nurse put some saline in the bowel so I can see the colon distend and make sure it's patent and that I'm not missing another distal atresia. So here's a study of a typical patient. You can see the distended bowel very nicely, and you can see the enema, and you can see that the enema refluxes into multiple small bowel loops because most of these babies have an incompetent ileocecal valve, but you do not reflux back into the distended bowel. And that's an indirect evidence that you've had a small bowel obstruction, i.e. likely an atresia, because you have a microcolon, the colon is patent, and you cannot reflux back into the distended loops. So that's really the sine qua non of these types of obstructions. You mentioned this already, and I have to say, I really approach this with humility speaking to surgeons in South Africa, because this is very much a South African contribution to pediatric surgery. We've come to understand this through the work of Lowe and Bernard, of course, and it just amazes me when I read these original papers. And again, you may have them already, but I will send them to you. I actually have the original papers, and it is just fascinating. This is, you know, decades before fetal surgery ever even existed or rose to the entered the field of pediatric surgery, and yet they were doing these elegant fetal canine and chick experiments that very nicely showed us really that the etiology of jejunal atresia and intestinal atresias in general, with the exception of the duodenum. Although I have to say that type 1 you described is very much like the duodenal atresias rather than the accidental events that occur, which we believe are responsible for the rest of small intestinal and colonic atresias. Now, one of the things I really enjoy about treating this problem is that I don't find that there are two patients who are exactly alike. There's always subtle differences between patients. And so when you enter, you really have to have some guiding questions that you ask yourself before you even approach the case. And I like to think of three questions. So the first question is, what is the best option to establish bowel continuity or the conditions for early initiation of feedings? And if you think about each of those questions, they each relate to a specific morbidity. So that question relates to the immediate morbidity, the morbidity of not being able to feed a baby early. The second question is, often, as you mentioned, there can be a short gut. So if you are dealing, and it's not always the case, but if you are dealing with short bowel, what is going to be the best option to preserve bowel length and absorptive capacity? And that of course, relates to the long-term morbidity of short gut. And the final question is, again, you mentioned that showed really nice pictures of dilated bowel. What is the best option to address grossly dilated bowel? Why? Because that sometimes can be what we call a latent morbidity. And I'll show you a case many, many, many years later, and we're seeing more of these patients. Often our general surgery colleagues will call us about them now, who have problems because they've had dilated bowel that functioned okay for a while, but still comes back to haunt them. Now, when you look at these three questions, sometimes you can come up with a plan that meets all three criteria, but sometimes they conflict. For example, you may have very dilated bowel, but you may also have short bowel. So if that's the case, you don't want to be sacrificing absorptive surface early on. You want to maintain all the bowel. So there's where you have to have a plan to give you the best solution that may not be able to be optimal for each of these three questions. And again, the essential operative steps, you mentioned them. You have to confirm the presence and type of atresia, exclude possible associated anomalies, confirm the patency of the remaining bowel, assess bowel length, establish bowel continuity if possible, resect or plicate bowel as appropriate. And one of the things I'd like to mention early is if I'm dealing with one of these cases and it's evident right away that I'm dealing with short bowel, I like to put a gastrostomy right away because I know that patient will need it. And I don't know in your environment how acceptable gastrostomies are, how easy they are to deal with. But in our environment, I always remind my colleagues do that early rather than having to come back into a case that has already been operated. So I'd like to just go over some cases. As you know, I'm really fond of case-based learning and teaching. So I'd like to go over some cases and just have you think about them. So here you have a type 4, and I agree very much with Professor Chitnis. You don't always have short bowel. In fact, many times there is reconstituted bowel distally and the bowel is fine in length. So here you have a type 4. You can see very distended bowel, about 20 to 25 centimeters from the ligament trites. You can see multiple atresias over here, and then the bowel reconstitutes and you have plenty of bowel. How would you deal with this? Okay, so here you have to think of the three things. Short bowel is not an issue, so you don't have to worry about preservation of very abnormally dilated bowel. You want to establish continuity and you want to deal with the distended bowel. So one way to go about this is to resect as much of the distended bowel as possible along with the atretic segments. And then usually if I'm not dealing with short bowel and I have plenty of distal bowel, I'll usually resect to about somewhere between 5 to 10 centimeters of the ligament trites, because obviously I'm not going to resect right to the ligament trites. And then whatever I have not resected, I will taper. So here you will see that these are the bowel ends. I then taper whatever part of the jejunum that is still there, and I do an end-to-end anastomosis. And again, here, it's not about preserving bowel length. So you fulfilled your goals by dealing with the distended bowel, establishing bowel continuity right away, and initiating feedings, hopefully soon after. Okay, here you have a neonatal bowel obstruction, okay? And you have a very, almost like what I would call a triple bubble, if you will. So you know that this is a very proximal obstruction. Now you've done an enema here, and the enema is showing you a microcolon, okay? Except for the rectum, of course, but it's showing you an unused colon. Now, what do you worry about going into this scenario? You have a very proximal obstruction and the microcolon. Should this be expected? And the question is, when you see this scenario, you have to suspect that you're going to deal with a case of severe short bowel syndrome. Why? Because with very proximal jejunal atresias, just like duodenal atresias, if you have the bowel normal past that, you shouldn't really have an unused colon because there's a lot of desquamation and so on. Really, most of the elements of the meconium, with the exception of the bile, should have passed through the distal bowel, and you should not have the typical microcolon. So the more proximal the obstruction, if everything else is normal, the less likely you are to get a microcolon. So when you have a proximal obstruction like this, plus a microcolon, you're going to go and operate on this patient expecting that this is likely going to be a challenging short bowel syndrome. And in fact, this is the patient not so long ago. And you can see there's about a 15 centimeter distended jejunal segment, but the maximal distension is about 3 centimeters. So not massively distended. And then you have a distal ileum about 3 to 4 centimeters. And the colon and appendix are normal. And this is a case of atresia most likely due to a midgut volvulus or significant compromise of the entire bowel segment. So what do you do in this case? Now, here again, you look at the three issues. Am I going to deal with this and plicate it or remove bowel or even invert it or injure it in any way? No, I do not want to do that. I do want to establish bowel continuity if possible. And short bowel is going to be an issue. So in this case, I just did a primary anastomosis, a primary JEJUNOILEAL anastomosis, accepting that I'm going to leave this bowel behind, but that I'm going to, and I put a gastrostomy that I'm going to be able to feed the baby at least some amount of feeds early on. And what happened here is that this is the anastomosis, gastrostomy, and then on this patient later on, we came and did a step procedure. And amazingly, because she had bowel continuity early and the bowel wasn't severely distended, we were actually able to feed her within about 2 weeks of doing all this. And this baby never developed TPN cholestasis because and this was actually before we had omega ven and liver preserving, liver protecting TPN. But this baby actually did very, very well and never developed TPN cholestasis, did go home on home TPN, but was weaned off it around 2 years of age. Okay, here again, you have a neonatal bowel obstruction, again, very proximal. And once again, here you've got a colon that looks like an unused colon. And again, you have to suspect that this is going to be bad. And you go in and you find this problem. So here now you have a severe inflammatory condition. This picture doesn't do it justice, but what I found here was a very distended jejunum and a big phlegmon, a severe inflammatory mass. I could not tell what's what. I couldn't see any distal bowel. And it was very clear that if I persisted, I'm going to cause very significant injury to any bowel that may still be there. So this was actually before we had access to SMOF and omega ven, these liver protecting TPN formulas. And in this case, I wanted to be able to trickle some feeds in this baby because I knew it may not be for quite a long time before we can give the baby enteral feed. So I ended up doing an end jejunostomy, knowing that I'm going to be dealing with significant fluid losses and so on. But it was the best option at that point and left everything else the same, and then came back about 4 weeks later. And it's amazing how things are better usually in 4 weeks, just like gastroschisis babies. They look like they have terrible matted bowel, but you come back in 3-4 weeks and the bowel is okay to work with. So here we mobilized the jejunostomy and we found just a big clump of dead bowel, really nothing to preserve, and then reconstituted at the colon. So, and this is an example of how sometimes you really have to think way forward. In other words, I'm not going to be able to solve all the problems today, but I'm going to try to do what I can today, and I know I'm coming back. So in this baby, we did a jejunocolic anastomosis. Again, did not taper the bowel. They really didn't want to do anything at that point, and then came back, and you can see the distended bowel here. So it was very interesting. The problem with this patient isn't so much that there was fluid losses or any of that. The problem is that patient kept getting infected broviacs by translocation. So there was significant overgrowth in this distended bowel, and we kept getting almost every 2 weeks a broviac infection. So we went in, did a step procedure on this patient, and the step procedure both lengthened the bowel and plicates the bowel. And that's important to understand that it's really not just a bowel lengthening procedure, but it's a very nice way to deal with very distended bowel as well that may not be functioning or that may be having problems of overgrowth. So here you see, and you see the anastomosis was widely patent. So sometimes when babies behave like that, people think, oh, it's an anastomotic stenosis. Very rarely is it an anastomotic stenosis. I don't recall really seeing that in a latent way. Usually it's the problem of the proximal loop that is not contracting well. So the step procedure takes care of both. And in fact, within a couple of months of doing that, we were able to get this baby off TPN completely and get the Broviac out. Now here you have a really challenging case. You have it's the type 4, but it does have short bowel. So you have multiple atresias. You have about 20 centimeters of ileum before you get to the colon and about 15 centimeters of jejunum. And you have multiple atresias. So what do you do here? So there's not one simple solution, but again, using those principles, I want to try to reconstitute the bowel, but it's clear that I'm not going to do 4 anastomosis, one of which is going to be like a 6-to-1 discrepancy. This bowel was really not enough. There wasn't enough length to really do much with it at the time. So what we did, left the jejunum closed, did the distal anastomosis and put in a tiny feeding tube from a mucus fistula all the way to the cecum to stent these anastomosis, left things as they are, then came back, studied those at 4 weeks of age, and they had all healed fine. So we went back and we took that loop, we stepped it to lengthen it and taper it, and we anastomosed it to the mucus fistula and put a gastrostomy. And amazingly, that patient had 40 centimeters of bowel total, increased to about 50 with the step. And by 1 year of age, he was off TPN. So it's really, you really have to plan forward for how to try to get these patients off. This is a type 2 ileal atresias, and the principle is as you get more distal, the challenges become less because usually it's easy to sacrifice the very distended loops. You don't tend to have short bowels, so many of these challenges really become less. So this is a type 2 distal atresia, and of course, it's a simple resection, primary anastomosis. Same thing, this is a type 3A ileal atresia with a segmental volvulus, so you can afford to remove the ischemic segment and do a primary end-to-end anastomosis. And I show you this case because it's one of the most fascinating cases I've had to deal with. So this was a 28-year-old man who had had a jejunal atresia repaired by a pediatric surgeon at birth and was in the children's hospital for 2 months. It took me several weeks to get his records, was in the children's hospital for 2 months with feeding problems, but eventually fed well and was discharged home and did very well for more than 2 decades, did really well, no issues whatsoever. And then around age 25, started to vomit bile. Went through multiple operations, lysis of adhesions, anastomotic stricture repair by general surgeons. I happened to be giving grand rounds on intestinal atresia when the general surgeon who had just been referred to said, "Oh, I think you're talking about my patient." And amazingly, when we went in, this is his study before. You can see the duodenum proximal jejunum. I was able to get the operative report from 28 years back, and this patient never had tapering. And when I saw him, he was really in bad shape. He had had a gastrostomy, a peg placed that was constantly draining bile because of his obstruction, and he was on full TPN. So here what we found, again, severely dilated jejunum, no stricture whatsoever. So we tapered this over a large Foley all the way to the ligament trites. And I have a 7-year follow-up on this patient, never had problems again. You can see the difference in the study before and after. So this is what I mean by a latent obstruction. You really sometimes have to think way forward. This is another really interesting case. So this is a baby who was diagnosed prenatally and was sent for a prenatal suspicion of Hirschsprung's disease. And this was the only time that I've ever seen a prenatal consult for Hirschsprung's disease, because as you know, Hirschsprung's disease cannot be really suspected prenatally. The perinatologist, the maternal fetal medicine specialist, thought it was because while we often teach students that you can't tell the difference between small bowel and large bowel in the first few months of life, prenatally, they often see scalloping of bowel like you see here, and they know it's colon. So he was suspicious, and this was the only distended segment, a colonic segment. So I thought, okay, let's see what happens. So at age 6 hours, baby with scaphoid belly, really no significant problem except a bit of a paucity of gas on one side, but bowel is not distended. But lo and behold, 12 hours later, baby is distended, and we have this. Immediate contrast enema, does not reflux into the small bowel, so blind ending colon, and we find this problem here. So this is a colonic atresia in the ascending colon. And it's really interesting. I've had several of these patients now, and in at least a good number of them, the ileocecal valve, I'm not sure why, tends to be competent. So these patients can actually have a closed loop obstruction. So again, people talk about, doing a temporary colostomy, tapering the colon. I don't really see any reason for this. You're not trying to preserve colonic length. So here just did a right hemicolectomy or right colectomy, basically removed the atresia, and then did a primary anastomosis of ileum to colon. Now, in this case, in colonic atresias, if you look at all the textbooks, they talk about Hirschsprung disease. You have to think, could this be Hirschsprung disease? And I think that's important, but it's overstated because the incidence of Hirschsprung disease in colonic atresia is around 2 to 5%. It's not higher than that. Nevertheless, before you anastomose, you should send part of the distal margin, the colonic margin, for ganglion cells. And I think if you're suspicious and you don't have that ability to get frozen, it's probably safer to do a temporary stoma, wait for your finals, and come back. Here's another patient we had recently, and now in this case, there's an incompetent ileocecal valve, very similar to the first case, except in this case, the obstruction is backfeeding into the distal ileum, and the surgeon, this wasn't my case, and this is the colonic reconstitution. The surgeon in this case decided to do a Bishop Coop anastomosis, and that worked very well. I'm not super fond of these anastomosis because I do think that you can still plicate, taper the bowel, and do an end-to-end anastomosis for most of these patients, but this is an option when you have significant size discrepancy. So the summary of what I wanted to say is that it really helps to think of those three guiding principles. You should have a methodical operative strategy when you go into these patients. Sometimes you need to do a tailored approach, meaning like I'm going to really customize it to this patient. And I'm going to think to what I'm going to do today, tomorrow, and potentially beyond. Often patience is rewarded, and the outcomes really for these patients in an environment where you have adequate support should be excellent. I do want to make one last point about intestinal atresias. We're actually trying to lobby and call this the Gutman syndrome after one of our predecessors here who passed away recently. Dr. Gutman described a syndrome of multiple intestinal atresias from the pylorus to the colon. And those patients are familial. They have been reported here in Quebec, but there have been multiple reports from Europe. I cannot recall if this has ever been reported in Africa. But what you see in these patients is calcifications throughout the abdomen and a gasless abdomen. And really, if you know about this syndrome, those patients should be palliated. They have no bowel to preserve. They usually have 50, 60, 70 atresias throughout the bowel. And this really should be called the Gutman syndrome. So just to the trainees, I'll give you the same advice I give my trainees. Your purpose in training should be the competence to treat the disease primarily, but it should not end there. It should also be the complications of the disease and the complications of the treatment of the disease. And these all are, fall in different categories. Also, on pediatric surgery, we deal with a lot of very rare phenomena, and you do not have to worry to see everything, even in a center, I'm sure as yours, that's very busy. You may not see everything, but one of the beauties of our specialty, certainly why I entered it, is it's a small community. We interact with each other, and we still help each other with cases all the time. And finally, I just want to put a little plug for this CB Clips. It's on Twitter, also on LinkedIn and Facebook. I hope as many of you join and interact as possible. It's been a wonderful way to share and learn together. And if you want to do a case, if you want to present a case, this is really my purpose for this year, is to have others guest present. And it's very, very simple. You just tape, I'll help you through the whole thing. You just essentially use your iPhone to record a 2-minute video, a short PowerPoint, and I'd be very happy to host you as one of the hosts of CB Clips. So thank you so much, and I hope we still have time for some interactions. This is how our city looks today, last night. I'm sure you're gonna feel very, very fortunate where you are, but we will get to a summer where it looks like this. So I hope to visit with you sometime, and I certainly hope to see some of you here.
Thank you very much, Sharif. That was quite interesting, informative, and educational. As you've seen, and as you see, Professor Larry Hadley is with us, and Professor Colin Lazarus, who was our ex-head of the department, and our mentor is also here. So I will invite Professor Hadley to give his thoughts and his comments, please, Prof. Hadley.
Yeah, Sharif, good to hear you again. And thanks for a very thought-provoking presentation. Your bent for history, it was worth noting that at the time of that report from Lowe, that Chris Barnard was a pediatric surgical registrar. So he was actually planning a career in pediatrics, didn't make the grade, and went on to train as a cardiothoracic surgeon. So for all the trainees, don't worry if you don't make it.
He did the first heart transplant, I think, right, Larry?
Huh?
I think he did the first heart transplant.
He did indeed, yes. Yes, that's where people who don't make the grade in pediatric surgery, that's where they end up. Also, I think we owe a great debt to H.H. Nixon, Harold Homewood Nixon, who was really the guy who pointed out the problems with that dilated bowel. And there is no doubt that if it's surgery, you flick the bowel, it'll contract. But it's a non-propulsive contraction. And he showed through a very elegant series of operations of experiments on isolated bowel that this dilated bowel was an ineffective propellant. And so the whole thesis of boldly resecting the proximal bowel came into being. And then since then, of course, we've had the taperings and the Delaromia inversions, etc. But Sharif, we work in Africa. And I'd like to know what your approach is to the patient who pitches up. He's 23 days old. He's got jejunal atresia. He looks like a stick of biltong. He is, shall we say, a poor operative risk, and TPN may not be available. And in fact, even for treating your straightforward intestinal atresia, TPN is probably not going to be available for many of the people on this participant list. So, you know, we've fussed over, should we give these people preoperative TPN and try and get them fit for surgery? And as you say, they all get Broviac infections and shuffle off this mortal coil with septicemia. Should we operate on them and then try and give them post-operative TPN, or try and get them early feeding, trickle feeding to try and tide them over, and they starve to death? And so whilst in the developed world, small bowel atresia might indeed be a done deal, in Africa, and I suspect in many other parts of the developing world, it's still a major problem. And I think we've got to reconsider our operative approach. And I think there may well be a place for feeding stomas and putting in a distal feeding catheter in a proximal jejunal atresia, etc. And the Bishop Coop, because you can feed the baby down the distal limb, aspirate what comes up the nasogastric tube and stick it down the distal limb. And it's going to be sort of what you would regard as rudimentary techniques like this that are going to improve the very significant mortality in Africa. So how would you approach it?
Yeah, I completely agree, Larry. In fact, if you look at the history of these types of anastomosis, the Centuli, the Bishop Coop, I mean, these were used essentially when we were in those settings. Like, we didn't have really that type of neonatal support, TPN support, etc. And I do agree that often, because you have venting chimneys and so on, that they do lead to earlier intervention. Now, and I've operated in Rwanda and other places with surgeons who face these dilemmas. For example, let me just give you a practical example. Type 1 jejunal atresia. I mean, first of all, I'm usually amazed that these babies have survived a couple of weeks without really any nutrition. We're not able to absorb anything. and I've avoided the resection altogether. You know, basically do what I described for duodenal atresia, and I often in very, very small babies would use a smallest catheter possible and feed distally as soon as possible. And that's their own, and despite that, the mortality is still extremely high. And I think the question really becomes an ethical one. If you have a very late presenting baby who you know is already in severe malnutrition, maybe even septic and so on, is there really a role for surgery at all? Or is really palliation the right way to go and not subject that baby to any intervention? And I don't have a right or wrong answer to that, but it's definitely worth at least considering. But I do agree with you that much of what I talked about are really meant to be for a high resource environment where the TPN support is available if needed, where you have good NICU support and so on. And South Africa is probably not an example, but for really the lowest income countries and where resources are very, very tight, your focus should be, how am I going to get this baby feeding very early? And I do agree that, at least in my experience with these, that something like a Bishop Coop does tend to allow you to feed sooner. So certainly it may be very well an option for many of these babies.
Yeah, thanks. With regard to duodenal atresia, I mean, we looked at our patients several years ago now, but in our environment, intestinal malrotation with a midgut volvulus is far more common than duodenal atresia. And so if you're going to make a mistake in this neck of the woods, then you should make the mistake of operating emergently and finding that, in fact, it's a duodenal atresia. Just to remind our speaker that malrotation without a volvulus doesn't present. It's asymptomatic, so you're never going to. If you've got a patient with malrotation who's symptomatic, he's got a volvulus, he's in danger of dying, stat him. So really, you've got to get on and do it. And the other thing that interested me was this concept of a subumbilical incision. I've never done one. Well, I mean, I've done a Phalansteel, but I don't see the advantage of a subumbilical transverse incision getting a transversical approach to the bowel. And it's interesting that you should present that paper by Richie Ricketts. I was in Atlanta and watching Richie Ricketts trying to learn how to do a laparoscopic fundoplication, and it was Vulcan who was teaching it.
Yeah.
And like me, he gave up. He said, "I'm too old for this. My arms are aching. I can't judge distances." So he went back to doing them open. And I think that just because something can be done laparoscopically doesn't mean it should be.
So I think that's a great point, and it's important for the trainees to really look at all this, what we think is dogma, to look at it critically. So we don't do a lot of fundoplications in Canada. We're very conservative. We don't, the operation is done very rarely. But I have stopped doing lab fundoplication in small babies in the NICU, the 3-4 kilo babies. I stopped because I do think the open operation is gentler. And here's what's really amazing. So we present the laparoscopic fundo as, the state of the art. In fact, the whole area of gastroesophageal reflux has very poor literature in surgery, but some of the best literature is actually open versus laparoscopic fundo. There are about 4 or 5 randomized controlled trials, and I summarize them in my chapter on reflux. And guess what? There has never been an advantage to laparoscopic fundoplication actually demonstrated in any of these. So again, you have to look at things a bit critically and not be accepting of just sort of, what becomes surgical dogma.
I couldn't agree more. Thanks, Milind.
Yes, thank you, Prof. Hadley. Now I just invite Professor Colin Lazarus, who is also one of very experienced surgeons, and I know he's quite fond of transanastomotic tubes, even in cases of small bowel atresia. And please, Colin, you can make your comments. Colin?
Colin's involved in dog training by the sound of it.
I don't know whether he's able to hear me or not. I will give one more try. Hello, Colin. I know there seems to be some problem. I think he's probably unable to hear me. Next, I will invite Dr. Itai Simango, who is a consultant pediatric surgeon and in charge of the unit in Port Elizabeth. But he has a very strong association with our department in East London, more than 20 years back. And he trained as a fellow in pediatric surgery, then worked as a consultant here. And only about 5 years ago, he relocated to Port Elizabeth. So Itai, your comments, please.
Thank you. Can you hear me?
Yes, yes, we can hear you.
We have had one patient with quite a proximal jejunal atresia, about 25 centimeters beyond the ligament of Dowel, presented, who was interesting in that the baby presented at between 4 to 6 weeks of age, and like the senior surgeon has commented, sometimes one is surprised the baby survived.
There's a lot of echo. Maybe just reduce the volume.
Hello.
Go ahead.
Can you hear me?
Yes, we can hear you.
The echo's coming from Dr. Mojola. I don't know if that could be muted. Yeah, we could try that.
How is it now?
Good.
It's good. It's good.
Okay, I was saying we had a late presenter as well of a jejunal atresia with probably between 20 and 25 centimeters as the level of the atresia beyond the ligament of Dowel, and the child presented at almost 6 weeks. And one wonders how the baby survived, because even the blood sugars were reasonable. The baby was not hypoglycemic. So there must be some absorption that went on in that proximal gut. We didn't try to do anything fancy. We do have TPN in Port Elizabeth, as everyone knows, probably other than Professor Emil. So because we didn't try to do anything fancy other than the initial day or two of resuscitation and getting urea and electrolytes corrected and so on, we repaired it because we felt we had no other choice. The usual way, as if the baby had presented early and decided the baby would take its chances. So we did a repair, put a central line, and once the nasogastric aspirates were low, we started slowly feeding the baby, and the baby is at home. I can't tell you why the baby survived. We certainly don't have a series. It was just one lucky patient we had, but the baby survived and is at home. The interesting thing being, of course, the baby presented at 6 weeks old and had survived. You know, I won't go into a long story. It's a long story how the mother thought why it was felt the baby had nothing wrong for more than a month, but the baby survived and is at home.
Well done.
Yes, thank you, Itai. Again, I think, Sharif, our problem here is we can give TPN, but after about 6-8 weeks of TPN, we run out of lines and we start getting complications of cholestasis, sepsis. So we personally haven't done any step procedure. I would like to ask Prof. Hadley if he has done any step procedure or he knows of step procedures being done in Durban. Prof. Hadley?
Yeah, I know step procedures being done in Durban. I haven't done one. Not many of my patients lived long enough to have one done. But Sam Sheikh has done a number of bowel lengthening procedures with relative success. I'm not sure that he's actually managed to get anybody off TPN in his practice. He has a couple of kids on home TPN at the moment, but certainly the intestinal absorption has been improved by the STEP procedure, even if it hasn't completely solved the problem.
So maybe I can just make a couple of comments about the STEP procedure.
Yes, please.
You know, the STEP procedure was invented by a medical student who's now a pediatric surgeon in Boston, Bay Kim. And one of the reasons, you know, when I read about it, I really thought it was fascinating is, you know, in the past when we used to do the Bianchis, it was always nerve-wracking because, you know, you're dealing with short bowel and you're trying to go through the mesenteric sheath and really worried about potentially damaging more bowel. And the nice thing about the STEP procedure is that the chances of causing bowel damage are really, really low. And it's really pretty easy to perform. It does not disrupt the mesentery in any way. So there's really no significant feasibility of getting bowel damage. However, the question is when, and I think this is the point again, Larry's point is excellent. Like how long do you need the patient to survive? So if you are going to do a STEP procedure, because a lot of people are talking about primary steps, you know, at the time of exploration, lengthening the bowel right away or early on. The problem is if you take bowel that's, let's say, total of 30 centimeters, you know, let's say you have a 15 centimeter jejunum and you make that, you know, 25, well, you're still going to have short bowel. You're not going to get off that patient off TPN. So where it really helps is in those late patients who are trying to get off TPN, you know, they're not far away, and giving them just an extra complement of bowel will tip them over. That's where I really feel it becomes helpful. And the point is you can't really get there right away. You have to usually wait at least until the patient is nearing a year of age or more. And therein lies the problem of still having to support them until they get to that point.
Yes, thank you. Yeah. Now I will invite Dr. Majola. Dr. Majola is one of the consultant pediatric surgeons, and he has done recently a case of type 4 jejunal atresia. The baby is recovering in the PICU. Dr. Majola?
Hi, thank you, Prof, for the invitation, and thanks, Crystal, for a good presentation, and also to Prof. Amil for his wonderful and incisive and also informative presentation. Thus far, I have no comments. Thank you.
Okay, thank you, Dr. Majola. Dr. Manik Chand is our consultant pediatric surgeon who trained with Professor Hadley and has been with us for about 3.5 years. So if she has any comment, Yashoda?
Hi, Prof. Yes, thank you. And thanks to Prof. Emil. That was really good and lovely pictures to see. And thanks for telling us how they do it on their side of the pond. I would just like to, and from Prof. Hadley's comments, you can clearly see who trained me because I still believe in the Bishop Coop as well. So, and I have done it on a few patients here. I just wanted to ask if any other consultants from other African institutions are on, what they prefer to do if they don't have any TPN and they need to feed the patient early.
I see Dr. Taurai Zimuno from Zimbabwe. Taurai, any comments?
Thank you, Prof. Well, as you already know, South Africa is Zimbabwe's supermarket now. And if South Africa doesn't have TPN, you can, it goes without saying what's happening up here. So we are almost always out of TPN. The few times that we do get it, it will keep coming from South Africa, and it will be awfully expensive for most of our patients. So it's really quite a difficult situation for us, and unfortunately, we needlessly lose some of our patients because we don't have the appropriate interventions. Thank you.
Thank you, Taurai. I see Dr. Funeko Kopolo is also here. Dr. Kopolo is a consultant pediatric surgeon in the 3rd unit in the Eastern Cape province. He is in charge of the unit in Umtata. Funeko, do you want to share any experience, make any comment?
All right, thank you very much, Prof, and thank you to the presenters and the visitor. Prof, from our side, we do have access to TPN.
Yes.
So that take a little bit longer to arrive. I think they ordered from Port Elizabeth. So I think much of the problem that we experience here is similar to what Dr. Itai have shared, that most commonly it's late presenters. But once we resuscitate them and we operate them, the outcomes are fairly, for straightforward jejunal atresia, the outcomes are fairly good, I would say. Other than that, thank you very much. Thank you for the platform.
Okay, no, that's perfect. I think I'll just request Dr. Emil to give his final thoughts, and then we can close the meeting. Sharif, it was really great having you. We are certainly going to rope you in for some future meetings. And please, if you think they are appropriate for your friends in Africa, please feel free and share the Google form to register for the meetings. Our aim is to spread education and establish contacts with our colleagues in Africa.
Well, I really want to applaud your efforts. And, despite the doom and gloom of COVID and all the things that we've gone through around the world, I think one of the things that's taught us that we are a smaller community than we believe we are. And I know that a lot of these meetings, weren't happening before because it was a big deal to travel. And, it was very nice still to see each other in person. I don't think that's ever going to go away. But I think COVID has made us a much smaller community, and it's just wonderful to be able to have these types of participations to really benefit all of those who don't have enough time, and also don't have the means to always travel to large meetings and so on. So I'm very honored to be with you today, and I look forward to future meetings by Zoom, and hopefully one day see you all in person. Thank you so much.
Thank you very much, Sharif. Thank you all. Thank you, Crystal, for nice presentation, Itai for mentoring, Prof. Hadley and Prof. Emil, and all our consultants and the delegates who are attending. Next week, we will have a talk on COVID and pediatric surgeon. So it's going to be quite an interesting talk by one of our medical officers, and we'll have a pediatric infectious disease specialist as an invited guest for that talk. So thank you. Have a good day, and bye-bye.
Thank you.
Bye-bye.